So what the purpose of today's event is sharing knowledge. It's about further improving our current knowledge on the World Health Organization's surgical safety checklist. It's to think about the current challenges facing everyone in the operating theatres, to consider the impact of human factors on the surgical checklist and patient safety, and consider whether the term never event that was brought in 2001 should be changed and updated. So just before we carry on through, just a few little bits of fun facts. So in NHS England, obviously we've got a list of 3 intraoperative surgical never events. And the most frequent month for when never events occur between April of 2013 and of March 2023 is October. The number of surgical swabs that's been retained recently since April 13 and March 2023 is 218 retained surgical swabs throughout NHS England. And wrong implant between April 20 and March 2023 has totaled 54. However, as managers, ODPs and theatre staff, we must also think about the words that we use when talking about never events and the possible repercussions. All theatre staff are fragile, they're upset, vulnerable, and we must learn to support one another at all times. So as we go through this presentation, have a think about your own organisation. Think about how the World Health Organization's surgical checklist is delivered. Local safety for standards for invasive procedures, how they integrate into your daily practice, and what daily challenges do we all face in the delivery of the surgical safety checklist. NHS England define a never event as a serious incident that are entirely preventable because guidance on safety recommendations providing strong systematic barriers are available at a national level and should have been implemented by all healthcare providers. This graph shows from NHS England from April 2012 up to December 2022, the number of the 3 intraoperative never events when COVID-19 outbreak began. And in NHS England and across the 4 nations, we've introduced further guidance called NATSIPS, which is the National Standards for Invasive Procedures, which is to enhance our knowledge on the surgical checklist and the delivery of that said procedure. As can be seen, wrong site surgery, retained objects post-procedure and wrong implants across NHS England in that 10 years, we've had over 3,155 incidences. And when we think about that, that is when patients have come to harm, may need a secondary surgery or further general anaesthetic to correct the never event that has occurred. Retained foreign objects from all 389 never event claims, as can be seen, instrumentation is the most highly retained foreign object post-procedure, then followed by swabs, guide wires, and needles. In terms of litigation costs to the NHS, that's been reported at £12.4 million in paying legal fees out for the damages due to 389 claims. The next few slides are images of showing retained surgical instruments. So as can be seen, we all have a surgical checklist to count our instruments into the operating field and out of the operating field. But as we all know, the operating theatre is very busy. It's a complex area, multifactorial, multidisciplinary team, and distractions can and will frequently occur. Types and themes of wrong implants or prosthesis that have occurred across NHS England, which can also occur across the 4 nations and indeed globally, as we all work in our operating theatres. The labelling and the packaging, human error, distraction, checking process, the time of day, documentation that we use, communication, how we talk to one another, abbreviations that may be used, the storage of implants, time pressures to get through our elective operating, the type of IT systems we have, training and staffing. So the next few slides are the quantitative research results from my thesis so far. In terms of how the thesis was done, NHS England is split into 7 regions, which gives us a total of 157 NHS trusts that could have participated. However, for the purpose of the research, 136 trusts was invited to participate in the research. This table here just shows the actual number of participants that was invited and the actual number that participated. So roughly 1 in 4 trusts across NHS England participated in this research, which is quite a good return for a thesis study. The results of why the surgical checklist isn't always undertaken is displayed across these several slides going forward. So training, 56% of respondents stated that training on how to deliver the checklist was not always offered by their local hospital or NHS trust. Guidance from the World Health Organization, respondents stated the guidance was clear from WHO and NHS England. In terms of multidisciplinary team working, 91% of respondents asked for collective training on checklists, human factors, and simulation training. And the types of checklists. When it was first launched in 2009, there was a caveat from the World Health Organization that gave us a building block that we could obviously manipulate and change the weighting, the style of the checklist to how we wanted it to be. So some trusts have both generic and speciality checklists, and that was to erode and remove unnecessary questions going forward. As can be seen, the surgical checklist has got 5 or 6 steps if you add in prep, stop, block. The debrief is the biggest step missed throughout NHS England, as 62% of respondents stated that the debrief rarely occurs after their operating list. Checklist champions. This is a role which is undertaken mainly by the ODPs following the audit, and that is to ensure that the checklist occurs, any changes to the checklist, and any training can be led on by checklist champions. Interestingly, 71% of respondents state that they always receive feedback following a never event, and 89% of respondents stated they would speak up if there was a patient safety concern in the operating theatre. So barriers to the checklist. Staff attitude. Staff attitude has also come out as part of the qualitative data in terms of why the checklist isn't always adhered to and why certain steps are missed out. Part of that could be to do with operational pressures, the staffing gaps we've got across theatres, and obviously the backlog that all operating theatres have got following COVID-19. Culture and time. 95% of the respondents stated that non-technical skills training should be provided, and 87% of respondents stated that training should be a combination of online, practical, and simulation. As part of that training, further research was done and asking for online e-learning modules for each step of the WHO safety checklist, and to have simulation video recorded days of how the checklist should be delivered and what problems we may be incurring as part of that delivery. So NATSIPs 2, this is a national safety standard for invasive procedures and originally was launched in September of 2015 and was relaunched again by the Centre of Perioperative Care on the 23rd of January 2023. It's known locally across the 4 nations in the UK as the NATSIPS 8 and contains information on consent and procedural verification, team brief, sign-in, time-out, implant use, reconciliation of items, sign-out, debrief, and handover. An audit question was asked on this particular subject regarding NATSIPs and LOCSIPs, and half of the respondents either strongly agreed or agree that NATSIPs have helped. An audit was undertaken in November 2021, asking if NATSIPs and LOCSIPs was across the entire operating theatre departments, and 6 trusts that participated in this research have yet still to implement LOCSIPs. So staffing and leadership. Are staff shortages hampering patient safety? So we've all got vacancies in our operating theatres, whether it be medical or non-medical. And as it can be seen on this slide, NHS England was broken down into the 7 regions. But look, interestingly, on the left-hand side, there was no strong argument. Therefore, the hypothesis stood that staffing didn't have an impact on never events across NHS England. The 3 current never events, according to NHS England, are wrong site surgery, retained foreign object post-procedure, and wrong implant or procedure. As part of this research, on here there are 2 additions, what staff have asked for, but there's also been a 3rd one from the qualitative research. So the theatre safety experts are asking for falls from operating tables to be added as a never event, inadvertent general anaesthetic, and non-airway surgical fires to be added to the list of never events. And NHS England in 2021 removed wrong level spinal surgery, as there is still further work to do on this to ensure that this type of surgery doesn't occur incorrectly. The phrase never event was introduced in 2001 by Ken Kaiser, and 82%, which was quite a vast, significant proportion of the participants, said that this phrase should remain. Tingle 2022 argues that the term should not change or be diluted, and argues that when a never event occurs, it cannot be excused. So going back to the NATSIPS 8, this is a simple infographic that the Patient Safety Learning Hub and Centre for Perioperative Care, myself, together as a triumvirate created as a 1-page A4, is a simple reminder of the NATSIPS 8 and the 3 current intraoperative never events. So the next stages to the research are to look at the qualitative research, undertake focus groups, then methodologically triangulate the findings. Something that I've been working on in the background is the prosthesis implant timeout. So when a surgeon asks for an implant, these are the steps that we've introduced at my organisation to help reduce the potential never event or error in terms of when prosthesis or implants are requested. So just a thought really to leave you with is processes we deal with daily are behavioural, physical and cognitive. When we're asked to perform a task, there are multiple factors influencing our decision. You as a staff member, you may have other stresses, well-being issues that you're thinking about, family problems. The task itself, have you done it before? Are you competent to do it? When was the last time you carried out that said competency? Technology, digital, paper, whiteboards, the internal working environment and background noise, the suction machines, the radio, conversations. local policies and guidance, NATSIPS 2, standard operating procedures and checklists, and possible external factors, labelling, product design, and deliveries. Staff should not be blamed or made scope gates. We are all human. We all make mistakes. It's how we prevent them moving forward. So that's the end of my presentation. And as I was saying at the introduction, in terms of the publication, this has actually been published here in the Perioperative Care and Operating Room Management, the contents of tonight's presentation. So if you want to do any further reading, I'll share this with yourselves, but please feel free. It's here and it's open and it's free access for everybody. So thank you very much for tonight. Has anybody got any questions?
Thank you very much. Thank you very much, Nigel. Thank you for that wealth of knowledge. I actually learned a lot of things. Though I work with in the UK, but not with the NHS. I'm actually hearing of NATSIP and LOCSIP for the first time, though we use the SSC in my hospital. I work with a private healthcare. So thank you for this. I have learned a lot from you. And now that we have all had the privilege of hearing from him, we now healthcare professional with a wealth of knowledge on patient safety and surgical outcome. I think it's time to open the floor for questions and answer section on enhancing patient safety and surgical outcome, the power of surgical safety checklist, which I guess and I know should have sparked curiosity and raised important points for discussion from everyone. So I would want us all to ask our questions now. We can raise our hand or use the chat function to indicate our questions so that everybody can participate and have the discussion together. I know that Nigel is ready to answer all our queries right now. The floor is open for everyone to ask questions.
Hello, Mr. Nigel. How are you?
Very well, thank you.
Sir, actually, I have a question. You asked one thing like you have prepare your own checklist during the insertion of implant. How can we implement it in our on setups? And please, can you share this checklist with me?
So yes, I'm more than happy to share that checklist with yourself. This was done collaboratively as a team following an incident at my organisation, and it was how we improve that step. And we felt as a multidisciplinary team that we didn't actually have a proper pause moment in the operating theatre for when implants are used. And that is why we devised that checklist. But yes, more than happy to share the prosthesis implant timeout, and that's what the purpose of today is about. It's about sharing the knowledge so that everybody can further enhance and improve patient safety. So yes, I'll email that over.
Yes, sir. Thank you so much. Wonderful.
Thank you very much for that. I also know the importance of the prosthesis pause because I'm actually an orthopedic scrub nurse with my hospital. So I would like to ask a question too, though, but before I would share how we do our own checklist. In the safety checklist, we know it's just 3 steps, which is the sign in, time out, and the sign out. For the NATSIP, that included briefing and debriefing in the steps. Do we do that for each patient, like the briefing and the debrief parts? Do we do that for each patient? Because what we do in practice in my hospital is a team brief before the start of the list, where we talk about all the patient at once, stating what is needed in terms of prosthesis, in terms of local anesthesia infiltration and all that, stating the type of patient and what is expected. Then at the end of the whole list, we do the same debrief to talk about how the list went, what was wrong, what should have been done, and all that. But for each patient, we do the SSC, which is just these 3 steps. And when it's an orthopedic patient, before we hand over each prosthesis, the surgeon and the scrub nurse will check, this is what I want, and they check that is in dates. Then they will pass it over to the scrub nurse and they implant it. And before the closing of the skin, we do the prosthesis pause, where the surgeon now highlighted all the implants he had used. That's what we do in practice. So my question is, do we do NATSIP or LOCSIP for each patient, which according to the steps includes the briefing and the debrief, or we just do it the way we do? Brief at the beginning and debrief at the end of the list. I'm not sure if you understand my question.
I think I do. So the team brief is technically to discuss the patients who's down for that session or the operating day. And then the team debrief is what occurs at the end of the operating session or at the end of the operating day. And you're quite right, it's discuss what could have been improvements could be made, a thank you from the surgeon, the anaesthetist, etc., and to discuss the next steps. And then for each patient, it's the 3 steps, as you've said, the sign, the timeout, and the sign out. In terms of the prosthesis implant timeout, that was brought in as an additional safety step to try and erode any human factors elements that may occur. And it just made everybody in the operating theatre to stop, quiet, and focus on those implants. So for us, obviously, we have to implant the data onto the computers, into the patient's record, and then keep a log on the orthopedic or whichever specialty implant book they are. But we found that doing this proper implant timeout, it refocused everybody to stop, and it actually made sure the surgeon, the scrub practitioner, and the circulating practitioner carried out all the checks in terms of the right side, the right implant, the right size, etc. So it worked. Everybody's going to be different how they work. This is just something that we brought in to enhance that safety check.
Thank you very much again. And I going through the messages in the chat room. Yeah. Everybody really, really appreciative of the presentation. And another person just asked for the material, the steps, which you have said you will share. You will share, of course. Thank you very much once again. I don't know if Adebutala has anything else to say.
I think, okay. First of all, thank you so much, Nigel, for sharing relevant information, very timely. Like Adenike said, the NATSIP, I'm not really familiar with that, but we do the debrief before the case starts. And the debrief session is always for all the cases combined, not per case, if you know what I mean, because sometimes there's really no time to do those things. And one of our biggest challenges in terms of implementing the safety checklist is in terms of trying to make people to pay attention during the checklist, like especially the timeout. The timeout basically means everything needs to stop at that point in time and everyone gets to concentrate. Like if it's the first case of the day, we make sure everyone introduces themselves and everyone, we know who is who, because sometimes you could have students in the room, you could have new staff members, you don't really know who is who because everyone gets to put on the same scrubs. So we really would need people to pay attention and then to make sure that if you're checking the site, the surgery site, you need to really check and see if it's a case that requires a display of X-ray. You really need to check and make sure the correct side is displayed and things like that. I think, thank you so much. That would be my contribution, that you shared relevant knowledge. I believe we're going to build up on that foundation and make significant improvements in our various institutions. I could see many hands raised. Can I call Oluwatoyin Akinlade? I think you have a question to have.
Yeah. No, thank you so much, Nigel. And thank you for organizing this. I just have a contribution about what the last contributor said about how you do the debriefing and all. I think it's institution dependent. I think it's whatever you find out that is happening more in your institution that you want to implement and find a way to make it right. For my own place, if the surgery requires you to mark a site as a surgeon, and you've not marked the site, there's no amount of pressure you put on me that will make me move the patient. I will tell you to go back and mark the site. That is when I can move the patient, even if you have signed your consent. If that is not done, nobody moves. As a scrub, as a circulator, I don't scrub, I circulate. Then also for Odu, we call it Odu in my place. Everybody meet 10 minutes before the procedure, and we talk about what is going to happen in that room for that day. The surgeon, the scrub nurse, if there's anybody that is going to be breaking anybody in, you let them know this time, so time somebody's going to scrub in and break this person. Everything that is going to happen in the room, everybody discusses. Then after the procedure, when a final count is done, we call it a debrief. We do it in such a way that if an implant is being used, that is what we talked about. So implant is being used, and this is done. We have the specimen taken to pathology, that to lab. Just say everything, and then we have correct. Everybody answers the one that pertains to them. Correct? Yes. So implant for the surgeon. The scrub says whatever instrument he or she feels is not working properly and needs to be addressed. The circulator says whatever I feel. Anything that happens during the case, nobody moves out of the operating room until that is done. If you need to go out because there's an emergency or something, then your assistant has to stay. If there's an emergency that they have to call you downstairs for maybe in the ER to come see a patient, then your assistant has to stay. And when that is correct, you have to, your assistant gets that information to you, and then you have to get back to me to tell me that is correct, so that I can mark that off my list that everybody agrees to the surgery. And that is what we do in my place. It's just a contribution. Thank you.
Yeah. So just to add on there, with the team brief, we've added in an additional couple of steps where we've mentioned that staff welfare and well-being are asked at the beginning of the operating list to make sure our participants are okay. And we state at the team brief when the best time will be possibly to do the debrief. So at least that's discussed at the very beginning of the operating list as well. I was looking at one of the questions in the sidebar. Checklist seems repetitive. Is there any way we can make it innovative and fun? So that's about looking at your particular checklist to make sure that questions aren't repeated or that questions are all necessary as well. Instead of being innovative and fun, I would say that each of the 5 steps is a serious step for that patient in our care. And I think it's time that we all focus and ensure that we're doing everything we can as a multidisciplinary team to ensure that patient has the best experience possible. I can see 2 other hands up at the minute.
Yeah, thank you so much. Mark, I think Mark has something to say.
Hi, good evening, everyone. So I would just like to add an input regarding for the surgical safety checklist. So for that is in what we're doing here in the Middle East, because I'm working in the Middle East. So upon the patient is actually put in operating room, so we have the holding area, who's the one receiving the patients. So we have, but I think we have a different policies as well. So for us, because in our hospital, we are in line with the international patient safety goals. That is the 6 goals. So for us, the IPSG4 that we are using, so it's actually inculcate in our institution to have the site markings that is actually done by the surgeon. So all the checklists that we are using is that for the verification until the time out and then sign out. So for that is you need to make sure as a circulator that the site marking was being done by the surgeon. And for the implants, what we are doing is, if we know that there's a case like orthopedic or also in urology, because we're doing the penile prosthesis, so we make sure that before the surgery that will be done tomorrow, is we already talk with the surgeons, so that in case that there's any lacking of implants to be prepared for tomorrow, is we are prepared for that. So also we lessen the time for the surgery, because it is important also for the safety checklist, or or also the operating room is the time of the surgery for us, the patient compromise any infections that we had. That's on me, sir. Thank you.
Thank you.
Thank you so much for that contribution. Does anyone else have anything else to say? Any questions, contributions? I think, oh, someone else is raising hand. Barry Abdul. You can unmute your microphone and say something. I think you have a contribution or a question. Barry, is it?
Can you please hear me? Hello.
Yeah,
Hello.
we can hear you now. Yeah.
Hi, everyone. I'm Khwaja Abdul Bari. Basically, I'm from Pakistan and currently in UAE. And I heard all of you, and I actually learned many things new, especially briefing and debriefing process. And I really appreciate your efforts to share the knowledge across the globe with practitioners, with the healthcare workers, and specifically operating department practitioners. And one thing I would like to add in this meeting is we talk about the surgical safety checklist, and all the things is related to patient safety and safety of healthcare workers.
Yeah.
So today is marked as the International Patient Safety Day, and the theme was patient safety by through engaging the patient. So we must look into this matter through the patient prospect to ensure the patient safety by engaging the patient. Like when we are carrying out the surgical safety checklist, sign-in process. So we must involve the patient, and we confirm different things from patient, like if it's written that it's right knee surgery or it's right arm surgery. So we must not only go through the surgeon notes or consultant notes, we must confirm from patient. So this is what I actually want to share with you guys. And thank you so much for having me, and God bless you.
Thank you so much. Yeah, that was brilliant contribution. Thank you so much. And another thing, Nigel, you mentioned auditing of checklists. Would you have a template for that, or share something related so that we can know more about the auditing of the checklist? Thank you.
I'm happy to share that. So from the thesis research, participants audit the use of the checklist to do a quantitative research, quantitative audit that shows how often the frequency of the WHO's check is undertaken, but it's more the qualitative side in terms of what is missed at which step. So yes, I'm happy to share a audit document with you and everybody on the call.
Okay, thank you so much.
Miss Addy, we have also audit of checklist. I would love to share with you also. We have a former audit tool on Excel sheet, and we audit like sign in, time out, and sign out. We audit area wise. Like I would love to share with you.
Okay, thank you so much. I believe the session is recorded, so when we share the replay on the website, on that very page, we're going to add a link to download all the documents, if that's okay with you. We're just taking your permission for that. Thank you so much. And at the same time, it's alarming to actually see the statistics on the rate of never events, retained surgical items in the patients, wrong implants. In fact, recently I heard in one of these developing countries that a brain surgery was performed on the wrong patient. That is alarming. Like it's gone through several stages, and for the patient to be at the receiving end, pass through several checks, and it wasn't detected until the operation was really carried out. So I believe we have a long way to go, and it's patient safety is the responsibility of everyone as well. Even though it's a teamwork, someone needs to take ownership at that point in time and initiate the process and make sure that everyone is compliant with that. So I want to use this opportunity to say thank you so much, Nigel, for honoring our invitation. I believe you are loaded and you've got lots more. I know the time is not enough. Yeah. Definitely, we might bring you back for more if that's okay with you. And
yeah, no problem. So I've nearly done my qualitative research. I've nearly written that up. So probably around Christmas time, I can give you the second half of what the research is finding and the triangulations from all three areas. Happy to do that. Okay. As I say, today, as someone's alluded to, is World Patient Safety Day, and it's about sharing the knowledge so that we can all learn together. We're all in it, no matter which hospital you work at, in which country. The most important person in that operating theatre is the patient at every time.
Yeah, thank you so much. Thank you. That's brilliant. So we can't wait to bring you back. So TORG, we always have a webinar every 2 weeks. In the next 2 weeks, we have another one for interviews for you NHS interviews, how to pass the competency questions. I think we have that, and we have more sessions coming. One on anesthesiology in the next 4 weeks, another one on collaboration with the operating room team, and by November ending, we have one on robotics surgery. I believe we have a very, very long list of topics to be covered, and definitely we will find a way to bring you in for continuation. So thank you so much for honoring our invitation, and to everyone that connected from all over the world. Good morning, good afternoon, good evening, good night. I'm not sure what